Hi, I'm Prateek, and in this video we're going to be looking at the Herpes Simplex type 1 virus and learn a little bit more about it. Remember, if you want thorough revision notes, exam cheat sheets, CPD, along with a huge bank of exam style questions and guidelines, head over to ExamineDental.com. We also have expert one-to-one mentoring sessions in order to help you ace those interviews and exams. So let's talk about the Herpes Simplex type 1 virus. This is an important virus as it causes both primary and secondary oral infections. The virus is a 4-layered structure. It first contains a core with double-stranded DNA. This is then surrounded by a capsid, and this capsid is made of capsomers. The capsid is then surrounded by a protein coat, and this protein coat is known as a tegument. Finally, the outermost layer is a lipid bilayer made up of glycoproteins. Ultimately, it's this bilayer that allows the virus to actually bind to cells. The Herpes Simplex type 1 virus is also sometimes known as HSV1, HHV1, or the human herpes virus 1. And, as I've mentioned, it creates both primary and secondary infections in the oral cavity. The primary infection caused by HSV1 is primary herpetic gingival stomatitis. This is an incredibly common condition, with nearly 99% of cases being subclinical infections or asymptomatic cases. Majority of patients who do present with symptoms are usually under the age of around 6. The virus is usually spread through droplets and aerosol, and typically the incubation period is around about 10 days. When the symptoms do develop, they usually last around 7 to 10 days as well. However, if a patient is slightly more unwell with this condition, for example they have pyrexia or they have lymphadenopathy, then they may be ill slightly longer. The classic areas in the mouth that are affected include the hard palate, the gingiva, as well as the dorsum of the tongue. So patients will usually present with dome-shaped vesicles that are quite tense. These can be up to 2 to 3 millimeters in size. They're also usually filled with a clear fluid. Some patients can even develop up to 100 vesicles in one go. After a few days, they often rupture and they leave behind really small ulcers. Sometimes these small, shallow ulcers can actually coalesce together and they may present with larger ulcers. Patients may also experience systemic symptoms, which include malaise, pyrexia and lymphadenopathy as mentioned. Because of the discomfort orally as well, some children may struggle to actually eat and drink, so they may require support for this. Diagnosing patients with primary stomatitis isn't usually something that requires special investigations. It's usually the classic signs and symptoms that line up with this diagnosis. Management is usually symptomatic management. It's a self-limiting condition that you just need to let run its course. Some examples of the conservative measures that you may recommend include lots of bed rest, soft diet, to keep hydrated. You may also recommend analgesia and even a chlorhexidine 0.2% mouth rinse. Additionally, if the areas are particularly sore, you could also recommend a benzidamine mouthwash as well to help numb those sore areas, which hopefully will then make it easier for the patient to eat and drink. The virus is incredibly contagious, so any utensils that the patient is using should not be shared amongst other individuals. So antivirals are effective, but only if they're given within the first 48 hours of vesicles actually appearing, or within 5 days of the prodromal symptoms developing. The typical antiviral of choice is acyclovir, and this can be given in a dose of 400 milligrams 3 times a day for 5 days. However, typically, antivirals aren't recommended because the majority of these patients are children, and unless they're immunocompromised, there is a good reason to give them the antivirals. This condition will manage itself and no intervention is necessary with the pharmacological management. However, if a patient is immunocompromised or immunosuppressed, then sometimes aggressive treatment is needed. For example, a patient who's got AIDS. In this situation, antivirals need to be given, along with further management. This further management may include more potent antivirals such as valacyclovir. Following the primary infection, a patient may then develop latent infection. This is where the virus travels to the trigeminal ganglion and it remains within the ganglion. It then stays here without causing any problems for the patient, and in about 50% of patients, the virus will remain dormant within the trigeminal ganglion. However, sometimes the virus can reactivate, in which case it migrates down the trigeminal nerve and starts being shed from the nerve endings. Classic reasons for why the virus may reactivate include illness, UV light and stress, essentially anything that may hamper the immune system. If the virus reactivates and travels down the trigeminal nerve like this, it then leads to the secondary infection, which is Herpes Labialis, or more commonly known as cold sores. Often, if this is going to occur, prior to the actual lesions developing, a patient will experience a prodromal tingling sensation or burning sensation in the area where the virus is going to be shed. Vesicles then usually form a couple of hours after this prodromal tingling, and usually these would form along the mucocutaneous junction of the lip. The vesicles may then start to enlarge, they then coalesce, and they may begin to weep a clear fluid. After a few days, they will rupture, and then they will start to crust over. The length of the cycle varies from patient to patient, but the average is around about 12 days. Again, if the patient is slightly more immunosuppressed or they're feeling a bit more under the weather, then this process may last a little bit longer. Herpes labialis is notoriously difficult to manage. You can get over-the-counter antiviral ointments that can be placed on these lesions. This includes a 5% acyclovir cream that must be applied 5 times a day for 5 days. However, these ointments are only really beneficial if they start to get applied from the point the prodromal tingling develops. If the vesicles have formed, then this is too late for any topical intervention. Ideally, you need to avoid the trigger factors that may lead to these lesions forming. Once the lesion forms, then you just need to allow the lesion to run its course and heal with time. The herpes simplex virus is extremely important when it comes to dentistry. You're probably aware that patients who present with cold sores should not be treated with an aerosol procedure. And this is because the virus can be picked up in the aerosol and be transferred elsewhere, including to eyes or even onto skin. When the virus causes a skin infection, it's referred to as herpetic whitlow, and this is an extremely difficult to treat and painful condition. Therefore, if you know that a patient has a cold sore, you should try to avoid treating them unless it's absolutely necessary, and generally you would want to avoid an aerosol procedure. So in this video, we've looked at the herpes simplex type 1 virus. We've looked at the structure of the virus, we've looked at the primary infection, which is herpetic stomatitis, and the secondary infection, Herpes Labialis. You can find more information over on the ExamineDental website with our revision note and cheat sheet on the herpes simplex type 1 virus. I hope you found this video useful, and if you did find it useful, please make sure to like, comment and subscribe. Until the next video, take care.